Hi, good evening everyone. So we'll be continuing our lecture series every week on one drug in dermatology. And this week we'll be tackling IVIg or IV immunoglobulin. We know it as IVIg, okay? Intravenous immunoglobulin dermatology. Now this might be a drug which many of the residents would not be much more comfortable with because this drug is not used that commonly. And it first of all, it's a costly drug. The only reason you will have access to it is because it's being provided free of cost in government hospitals. Maybe that is why you might come in contact with IVIg. Otherwise the cost is a very prohibitive factor for this drug. So what essentially IVIg is, these are just a pooled plasma, or you could say a blood is collected from a lot of individuals, and immunoglobulins are extracted predominantly. The immunoglobulin IVIg, sorry, IgG immunoglobulin is extracted and collected to form a concentrated solution. Okay, so that is what IVIg is, and the potential use or the potential of IVIg in dermatology is majorly in the autoimmune disorders or immune-based disorders. And the way it acts is that the immunoglobulins kind of competes with the endogenous antibodies and try to neutralize or rather destroy the endogenous antibodies against any antigens which you might see in various skin disorders. So that is how IVIg works. Very short, but we'll be discussing IVIg in much more detail in subsequent slides. And at the end of this video, you should be able to recapitulate what exactly are IV immunoglobulins and what are the uses of IVIg, what all are the mechanism of action of IVIg and associated side effects. Okay, so with that out of the way, we can start with IVIg this week. Now, IVIg started as intramuscular injections predominantly in antibody deficiency syndromes and some viral diseases. So that's how it was started, and it was, I think, around 1960s. Okay, so at 1960s it started as intramuscular injections first. In 1980s, you started having IV formulations. That means initially as intramuscular, then the formulations became intravenous. Okay, now what happens is roughly more than 1,000 healthy donors are the source for this immunoglobulins. So you have a cohort of 100 or more than 100 healthy donors, and from that the plasma is extracted. And then immunoglobulins are extracted. Okay, and the method of extracting those immunoglobulins from these blood donated from more than 1,000 different healthy donors is known as cold ethanol fractionation. Now, essentially, there are four methods. I will not be naming them because only the cold ethanol fractionation method is the one which is most commonly used and most widely used. So, the method is cold ethanol fractionation. There are other methods, chromatography and all that, but we should focus mainly on the cold ethanol fractionation. So, what happens is you collect blood from more than 1,000 individuals and then you isolate immunoglobulins by using the cold ethanol fractionation. Okay. Now, what IVIg has is it has majorly immunoglobulin of IgG type. Okay, so let me just write it here. IgG is the major immunoglobulin in IVIg, more than 95%. And other immunoglobulins, namely IgA, IgM, IgD, these constitute the remaining 5%. There are other constituents also, namely you can have sucrose, salt, albumin, and when I say salt, I don't mean NaCl, sorry, albumin, NaCl. It can be KCl and all sulfates and phosphates and all those salts. Okay. Now the dose of IVIg, this point is important. The dose is 2 gram per kg in 3 to 5 divided doses over 3 to 5 days every month. The infusion is over 4 to 4.5 hours. Okay. So what we do is we calculate, let's say you have an individual of 70 kgs. Okay. So 2 gram per kg makes it 140. You divide it into 5 parts. 5 parts would be roughly what? That would be Okay, so 70 kg into 5, sorry, into 2. 2 will lead to 140 gram, the total dose. You divide it by 5, you get 28 gram per day into 5 days. So every day you have to give 28 gram of IVIg if you are treating a 70 kg individual. And this 5 days is what is known as a cycle of IVIg. Okay, if you're giving it in 3 days, then this has to be divided by 3, and you get the amount of IVIg in 1 day, and you give it over 3 or 5 days, and this collection of days is known as one cycle, and you have to give one cycle every month. Okay, the infusion time is roughly 4 to 4.5 hours, but it can range from as low as 2.5 to as high as 10 hours depending on the speed of infusion. And since the immunoglobulins can come from various manufacturers, even a manufacturer would have a specific set of instructions how to prepare IVIg, how to dilute it, and what should be the ideal time of infusion. So it can vary from one company to another company. So make sure that you read the inset that comes with the IVIg, so that you can know that what particular brand you're using and what is the correct way of diluting it. So it comes in two forms: lyophilized or ready to use one. Lyophilized has to be reconstituted, so it has to be made again, while ready to use can be easily used just out of the vial. Nowadays mostly we use ready to use, not the lyophilized one. Okay, so let's move forward. Now this is a structure of an immunoglobulin. So this is Ig. Okay, so it consists of a Fc region. This one, the arm, the single arm. So that is known as FC. C for constant or complement binding. There are many notations for C, but this is the FC region. While the two forks that we see here, the two different appendages, that forms the FAB region, or the antibody or the antigen binding site. Okay, FAB region. This is the structure of an immunoglobulin. So just in subsequent discussion, we'll be discussing about the function of the FC part and the FAB part, majorly the FC part. So just keep this in mind. It's a Y-shaped, that's how we usually draw immunoglobulin. So it's a Y-shaped immunoglobulin, and this part is known as FAB, while this part is known as FC. Clear? So let's move forward. Now, in pharmacology of IVIg, we know that the major constituent is IgG. So IgG is more than 95%, and the other 5% has other immunoglobulins, albumin, sugars, salts, preservatives, and everything else. Okay. The peak serum concentration occurs immediately as the infusion is started. And when the infusion started, within the first 24 hours, 30% is catabolized. It is metabolized by the body. So remember that IV immunoglobulins are nothing but immunoglobulins from a human source. Okay, and they will be treated as immunoglobulins in the body. So when you inject a high amount, a pharmacological doses of immunoglobulins, they are essentially but proteins, and they will be degraded by the body. So within the first 24 hours, 30% of immunoglobulins are catabolized or metabolized. When the infusion is started, majorly 60% is inside the vessels, while 40% it goes inside the tissues. It crosses the placenta and may be excreted into milk. Now remember that IgG endogenous. Okay, so endogenous IgG, or the IgG naturally produced by the body, also crosses the placenta and may be excreted into the breast milk. And since this is the immunoglobulins, the intravenous immunoglobulins are nothing but a collection of IgG, it will behave the same. Okay, so it will cross the placenta, it will be excreted into the milk. The half-life is 2 to 5 weeks. So in various areas it is written 3 to 6 weeks, 3 to 5 weeks, but this is, I am quoting Wolverton. So 2 to 5 weeks is the half-life, and that is why you have a cycle of once a month. So you have a monthly cycle of IVIg. Okay, so it's around 2 to 5 weeks. Let us discuss the mechanism of action in quick detail, and if you understand the way IVIg works in the body, the mechanism of action of IVIg, you will be easily able to remember what are the uses. Okay, you wouldn't have to memorize a list of sorts that these are the disorders in which IVIg can be used. All you need to know that what is the mechanism of action of IVIg and in what all disorders this the mechanism is implicated. So when you block that with IVIg, you will know that this is also an indication for intravenous immunoglobulin. So the mechanism of action includes reduced antibody production, complement system modulation, cytokine modulation, circulating antibodies and receptors, T cell activation, dendritic cell modulation, immune cell trafficking, fast ligand interactions, and synergistic effect with corticosteroids. Okay, so subsequently, very quickly, we are going to discuss each and every different mechanism of action. How does IVIg reduces antibody production? Now remember that I told you that in immunoglobulin, this part is known as the Fc part. Okay, so the Fc part will bind to a B cell. So let me just draw a B cell quickly here. This is a B cell, and this will be a receptor. This will be a receptor. Okay. Now, what are B cells? What are the function of B cells? B cells have the capacity to generate antibodies. And what will tell B cells that a lot of antibodies have been formed? This receptor. So what happens is naturally or a normal physiologically or pathologically, when B cells are secreting a lot of immunoglobulins, the immunoglobulins will come and bind to this area, bind to the receptor. Let me just make it properly. Yeah. So what happens is that these immunoglobulins will bind to this receptor and signal B cells that, hey, you have made a lot of antibodies, now stop. Okay. So the FC arm of the immunoglobulin binds to B cell receptors as a negative feedback that you have made a lot of antibodies, now you can stop. What happens when you kind of give a lot of IVIg from outside? So you have an exogenous IVIg, exogenous, okay? You are increasing the probability of interaction of the Fc component to the receptor. Okay, and when this IVIg, the thing that we have given intravenously, attaches itself to the receptor at B cell, you have again the negative loop, and that is why the B cells stop producing antibodies. Clear? So that's one mechanism. Second mechanism is by neonatal Fc receptor. Now what happens is that you have a neonatal Fc receptor. That means you have a receptor. Let's just make this. You have a receptor. Okay, this is a receptor and it will bind to endogenous endogenous IgG. Okay. Now what happens is this binding kind of prevents the Ig from getting destroyed. And why it is known as neonatal Fc receptor? That this receptor binds to the endogenous immunoglobulin and safely lets it cross the placenta and go inside the neonate. Okay, so that's how that is what the function of Fc receptor is. So neonatal Fc receptor are responsible to prevent the degradation of IgG. Okay, there's a huge mechanism involved. You have endoplasmic reticulum mediated damage of IgG, and Fc receptor blocks that damage, blocks the receptors, blocks the lysosome from destroying the IgG. What happens is if you give intravenous immunoglobulins, they will attach itself to the neonatal Fc receptor instead of body's immunoglobulins. Okay, and the body's immunoglobulins will not be able to attach to Fc receptor, and they will be degraded by the cells. So that is how the IVIg is decreasing the formation. Okay, let me just say it again. It decreases the formation and it increases the degradation of immunoglobulins. Clear? So IVIg saturates neonatal receptors, increase the degradation of endogenous IgG. Okay, so it stops the formation and it increases the destruction of IgG. Clear? Let's move forward. Complement system suppression is easy. IVIg blocks the C3 and C5 convertase and inhibits tissue deposition. Okay, so what happens is maybe sometimes in the future I will cover the complement system activation. It's a very interesting system to know about. So what happens is there's a stepwise conversion from C3 to C3A, C5, C5A, and all that. These are all carried out by enzymes known as convertases. So what happens is IVIg blocks this. Okay, IVIg blocks this convertase enzyme, namely C3 and C5, and when these are blocked, the whole cascade is blocked. The cascade is blocked. Okay, and no complements are active. And what is the function of complement system? It complements the immune reaction. Okay, it increases the viability of cells to get destroyed. It increases inflammation and lot. So IVIg decreases that. It inhibits tissue deposition, which becomes very important in the pathomechanism of dermatomyositis. We'll discuss in the future, no problem. Now, some parts of the complement system come together and form MAC. MAC is membrane attack complex. So what happens is you have a cell. This is MAC, membrane attack complex. It causes holes inside the cell. And when there are holes inside the cell, the material leaks out and the cell dies. So this is membrane attack complex. This membrane attack complex is blocked by IVIg. So when this is blocked, the inflammation is also reduced. The cell destruction is reduced and apoptosis is also reduced. So you are able to decrease the inflammatory damage to the body. Okay, so MAC is blocked. And it blocks the complement pathway at an earlier stage. I've told you that the whole cascade is blocked because the convertases are blocked because of IVIg. Clear? Cytokine modulation. Now interleukin 1, 2, 3, 4, 5, barring the 10-1, TNF alpha, the major inflammatory cytokine, GM-CSF are responsible for increasing the number of inflammatory cells. Yeah, GM-CSF granulocyte monocyte colony stimulating factor. Okay, so it is responsible for increasing the number of inflammatory cells. So what happens is IVIg modulates this. IVIg modulates the formation and the subsequent release of these kind of inflammatory cytokines. It also inhibits lymphoproliferative response. So you can say that GMCF modulation kind of leads to a modulation of lymphoproliferative processes. IVIg inhibits lymphoproliferative responses, and that is why you don't have a lot of lymphocytes and thus not a lot of inflammation. Helper T cell modulation. So if you have seen my video on immunology of leprosy or pathomechanism of psoriasis, I have discussed that helper T cells decreases inflammation. So when inflammation cascade is happening, helper T cell will decrease inflammation. And when these are modulated by IVIg, IVIg will lead to formation of good amount of helper T cells, which will further decrease inflammation. Clear? Okay, next. Circulating antibodies and receptors. What happens is that when we give IVIg, since I told you that this is the immunoglobulin, this is the Fc receptor. Okay. So what happens is when, let's say you have a macrophage, okay, and here we have a receptor for IVIg. Let's make a receptor. Yeah, receptor for IVIg. So what happens is when these receptors are saturated by the attachment of immunoglobulins, the macrophage will think, okay, let me just label it, this is a macrophage. Okay, so macrophage will think that there is a lot of immunoglobulin surrounding. It cannot differentiate between the body's immunoglobulin or the therapy immunoglobulin. Okay, so a lot of receptors get saturated with this immunoglobulins, and this will lead to saturations will lead to either the modulation of macrophage or it will lead to destruction of those macrophage. Okay, that means the macrophage will somewhat think that the humoral immunity is not taken care of and it will start to downregulate it. Okay, and if these receptors are downregulated, the mechanism by which antibodies leads to activation of macrophage is also reduced. Let me tell you how. Let me just get rid of this. Yeah. So what happens is that this is a normal macrophage, normal receptor, a normal immunoglobulin. Let me just make a normal immunoglobulin. A normal immunoglobulin attaches itself, and this will lead to inflammation or inflammatory activity, which is normal. What happens is IVIg attaches itself, but is not able to initiate that signals which is required for macrophage to have its inflammatory activity. So it kind of blocks the receptor, and the body's immunoglobulins are not able to attach itself to macrophage, and thus the macrophage activity and function is reduced. Okay. Now many of these antibodies are required, and when I say antibodies, I mean the body's antibodies. The body's antibodies are required for various activation of different kind of cells involved in inflammation. So when these receptors on these cells are blocked by outside IVIg, the inside IVIg is not able, the inside Ig is not able to attach itself to the cells. Okay, so let me explain with an example. If I have to tell somebody that you should do your job properly, but if somebody else comes and prohibits me from meeting that person, I will never be able to convey that message that do your job properly. And macrophage will not know that they need to do their job. And that's why they will just keep on sitting and sitting idly till the inflammation is over. So are we clear? So FCR gamma B. So it's a type of FC receptor. That means it's a receptor for the FC part of immunoglobulin. And this will lead to degradation. So what happens is, okay, let me just explain it very quickly. I would need a bit of empty space. Okay, there should I draw? Yeah. So let's say that this is FC. This is FCR gamma B. Normally, what happens is that it will attach the FC part of endogenous immunoglobulin, and this will lead to destruction. It's a bit of detailed mechanism, ubiquitination, proteasomal mediated destruction. The function of FcR gamma B is to catch hold of immunoglobulins and destroy them. What IVIg does is it increases FcR gamma B. It increases FcR gamma B. And when FcR gamma B is increased, it will lead to increased degradation of all the immunoglobulins, including the one the body is making in the disease. And thus the inflammation is reduced. Clear? Let's move on. Now T cell activation. Yeah. So the amount of different cytokines and attaching factors like MHC1 and MHC2 molecules, they are supposed to act as a negative feedback. Okay, so when these receptors are continuously being attached by immunoglobulins, they will know that yes, a lot of immunoglobulins are there in the system. And since they are getting constantly activated, they will try to down regulate the inflammation. Okay, let's say I'm a T cell and now I'm killing a lot of pathogens, and that pathogens are getting killed by the antibodies from the B cells also. When there are a lot of antibodies in the system and they will interact with me and tell me that hey, there are a lot of antibodies in the system, you should decrease your inflammatory activity because we have other people to take care of that. So I will decrease my T cell activity. So what IVIg does, it acts as a excess source of IgG, which when when bound to T cell receptor will decrease their function. Okay. It also downregulates co-stimulatory molecules like lymphocyte function associated antigen and others like CD28 and all that, CARTLA and all, and interface with T cell activation. There is a non-specific activation of T cells which leads to their destruction. The activation should always be specific. Okay, if it's non-specific activation, it will lead to destruction of T cells. Clear? And restoration of T helper cells. As we have already discussed before, that the T helper cells is inhibitory in nature, and under the action of IVIg, it is much more properly working and decreasing the overall inflammation. Clear? Dendritic cell activation. So multiple studies have said that dendritic cells are the primary target of IVIg, and what happens is IVIg affects the differentiation, maturation and function of dendritic cells. Okay, so let's say you have a chotu dendritic cell, little dendritic cell, and IVIg is going to attach itself via various receptors to dendritic cells and will affect the differentiation from, let's say, plasmacytoid to myeloid lineage, or maturation, that means immature or naive dendritic cell to a mature dendritic cell, and subsequently antigen presenting function of dendritic cells is also affected by the action of IVIg. Immune cell trafficking. Okay, so immune cell trafficking is IVIg may affect the migration of immunocompetent cells from the blood to target tissue. We have spoken a lot about immune cell migration, isn't it? So you have endothelial cells in the blood vessels, and the immune cell migration is that when inflammatory cells from the blood vessels squeeze in between the endothelial cells and comes to the tissue where the action is happening. IVIg reduces that. Predominantly, the reduction is through the reduction of ICAM1, which is intercellular cell adhesion molecule. Okay, one. Antibodies, which means the antibodies, the IVIg. Here, the antibodies mean IVIg. IVIg inhibits cellular adhesion and subsequent cellular migration, thereby decreasing inflammation. So, what IVIg does is this. Let's say this is the endothelial cell layer. Okay, so and this is the inflammatory cell. So first inflammatory cell has to attach itself. This is known as adhesion. Remember Robin's MBBS second year? So this is adhesion. Then comes rolling, and then comes squeezing. So in rolling, the immune cell rolls, and in squeezing, it squeezes itself in between the endothelial cells. There are a lot more steps involved. Maybe if anybody willing, I can discuss diapedesis and nuclear migration of inflammatory cells. Now, IVIg inhibits this whole adhesion and processes, and the inflammatory cells are not able to reach the site of injury, and the inflammation is decreased. Okay, so immune cell trafficking or immune cell migration is affected by IVIg. Fast ligand. So this is very interesting. So what happens is you have an immune cell. So okay. So I don't remember which cell has the fast antigen and which cell has the fast ligand. Okay, the fast receptor and the fast ligand. But one of them is present on the immune cells, the other is present on a cell, any cell of the body. And when these two interact, known as the fast ligand interaction, this will give signals to kill the cell. So let's say, for example, this is an immune cell and this is a normal cell. Okay, so a normal cell will express a lot of fast ligands, and when these get attached to the receptors on the immune cells, a signaling cascade will start. And if I don't remember it correctly, but I think the caspase 3 and 9 and 3 and 8 and 9 are involved. But because of the involvement of different caspases, apoptosis happens. So very simply put, IVIg has anti-fast receptor antibodies. Okay, so what happens is you have a keratinocyte. When that is damaged or the cell is not able to function properly, it will release a lot of fast receptors or fast ligands. Then you have an immune cells. It has the ligand for all of this, and when this thing gets attached to this thing, it will lead to keratinocyte apoptosis. What IVIg does is IVIg blocks this. IVIg blocks the fast receptors, and when fast receptors are blocked, the interaction doesn't happen, and you'd have a suppression of keratinocyte apoptosis. This function is important in SJS-TN syndrome, in which fast ligand death domain receptor pathway is implicated for destruction of skin or destruction of keratinocytes. Okay. Now, this fast ligand interaction by IVIg can also induce selective T cell and B cell apoptosis, thereby causing immune suppression. So, IVIg is stopping the apoptosis of keratinocyte and also increasing the apoptosis of T cells and B cells. And that is how inflammation is reduced and the skin keratinocytes are saved. So the major function of this mechanism is seen in SJS-TEN. Synergistic effect with corticosteroids. So it has been shown in multiple studies that use of IVIg reduces dose requirement for systemic steroids. Mainly you see this in SJS-TEN or you see in atopic dermatitis. It increases the glucocorticoid receptor sensitivity. So the receptor, this is the glucocorticoid receptor, let's say GLU, and this is the normal endogenous steroids or exogenous steroids if you're treating a patient, and this sensitivity is increased via IVIg. Okay, and that is how the receptor is more sensitive to steroids, and the action of steroids is potentiated or increased in the presence of IVIg. IVIg and corticosteroid can synergistically suppress lymphocyte activation. If you want to know how steroids lead to inflammatory suppression, there are separate videos. It's a three-part video on the action of steroids and the side effects of steroids. Go and see that. You will be clearly able to understand the glucocorticoid effects of steroids and how an IVIg increases those effects of steroids. Okay. Now, these are the different mechanisms of action of IV immunoglobulin. We have covered the 9 basic ones, but look at how long this list is. Stimulation of Fc gamma RB, blocking of Fc receptor, masking of autoantigen, neutralization of molecules and cytokines, formation of immune complexes, elimination of autoantigens, superantigens, binding of HLA1 molecule, apoptosis induction, binding activation of FAS, CD5. There's a whole list available. Increase FcRn saturation, increase catabolism of autoantibodies. This is a very big list. So all I want you to do is just go through it so that while if let's say a short note comes on IVIg or in your Viva questions about IVIg are asked, you'll be able to just keep on going on about different type of mechanism of action. So this kind of long list tells us that we are not entirely sure what is the major mechanism or minor mechanism of action, but a lot of varied effects of IVIg has been described in literature. Okay, so in the description of this video, I'll put the citation so that you can copy paste and read the whole article. It is an article by Forbati et al. Intravenous Immunoglobulins in Dermatology, Part 1. Okay, so you go through that article. It's a very good article. Now, how to administer IVIg? So, if it comes as lyophilized form, so you have a vial which is lyophilized. Very bad vial, very bad vial. Please bear with me. Whatever, lyophilized vial. You can dilute it with water, normal saline on 5% dextrose, and reach a dilution of 3 to 12%. Remember that there can be not marketeers. Since there are different manufacturers of IVIg, every manufacturer will have their own idea of how to dilute IVIg. Clear? So all I want to do is, if any IVIg you are using, just open the packet and read the product inserts that the manufacturer has provided, so that you know what should be the ideal solution and the ideal dilution of IVIg. So you start the infusion very low. Okay, it's and that is increased slowly. Remember, IVIg is given as a slow infusion. You can start as 12.5 ml per hour infusion rate or 25 ml per hour, depending on the tolerability to the patient. Okay, so many side effects occur because of high infusion rate, and a slow infusion rate is safer and better. Okay, you measure vitals every 15 minutes for the first hour, and then every 30 minutes for the remaining time of infusion till the vial is empty. So that's how you're supposed to measure vitals: 15 minutes 4 times, and then every half an hour till the infusion runs out. So these are 2 vials, and a lot different vials are available. Lot of manufacturers. This is just to show how a vial looks like. So here you have the 5% one, and here you have the 10% one. The 10% is 100 milligram per ml. The 5% is 50 milligram per ml. You just have to calculate the doses that I have seen. Let me just recapitulate it again. You have a 70 kg individual. Multiply that by 2. You will get 140 gram. This is the total value, total amount of IVIg to be administered. You divide that by 5. You get 28 gram. So 28 gram every day for 5 days is one cycle. Okay, and that's how we calculate. So this 28 gram, one vial has 100 grams. Sorry, not 100 grams, 0.1 milligram per ml. Okay, so this is 100 ml, and each ml has 50 milligram into 100 divided by 1000. That means this vial will have 5 gram per vial, the complete vial. This will have 10 gram per complete vial. You want to give 28 every day. So subsequently either 5 or 6 vials or 3 vials of 10%. You just have to dilute it and put into the infusion rate. Okay. Now, therapeutic guidelines. Therapeutic guidelines means when you should, why and when you should consider the use of IVIg. When the disease is progressive, uncontrolled, rapidly debilitating disease activity despite conventional therapy. That means IVIg is usually not the first line therapy, except maybe let's say diseases like Kawasaki disease, where it's the FDA approved indication. So when the conventional therapy is failed in a rapidly progressive disease, you may consider IVIg. Or if you have significant adverse events or adverse effects of conventional therapy, which can be life-threatening or morbidity-inducing. So if you're using conventional therapy, it's working also, but the side effects are so much that you need to consider IVIg. If the conventional therapy or long-term systemic corticosteroid therapy is contraindicated, whether it is relative or absolute, so consider IVIg when the corticosteroid therapy is contraindicated. Fourth point is that the patient does not have a contraindication to IVIg. Clear? The disease is progressive, that means it is still not getting controlled. And one more point which I have found in one article, which the citation I will include in the description below the video, so you can go and read. One was rapidly progressive epidermolysis bullosa acquisita with generalized cutaneous disease. So just one more indication where IVIg could be used. Uses. Again, remember my dictum that you're not supposed to remember the uses. You just have to remember the headings. So one is vascular disease, in which you have the Kawasaki disease, the FDA approved indication, ANCA positive vasculitis, livedoid vasculopathy. Then you have the autoimmune connective tissue disorders. Remember I mentioned dermatomyositis before. So dermatomyositis, scleroderma, scleromyxedema, SLE. Autoimmune bullous dermatosis, which might be the most common indication in skin. You have pemphigus vulgaris foliaceus, bullous pemphigoid, mucous membrane pemphigoid, epidermolysis bullosa acquisita, herpes gestationis, linear IgA disease. Okay. Other dermatoses include urticaria, atopic dermatitis, graft versus host disease, pyoderma gangrenosum, maybe psoriasis. Other dermatoses also include 10 SGS-TN syndrome, DRESS syndrome. So I've just go through this list once, and you will automatically just remember the headings, and you will easily remember 10 to 15 uses of IVIg. Now this is a list of dermatological diseases treated with IV immunoglobulins. I'm not going again, Kawasaki, dermatomyositis and all that, blah blah blah. You have the whole list. It is the same list but a shorter list if you just want to remember names. But it's better to go back and look at the headings only. Clear? So now that we have crossed the list of skin disorders which are treated with IVIg, very quickly, one slide each, I'm going to tell about few points, 2 or 3 special points about skin disorders, starting with dermatomyositis. Okay, so dermatomyositis. Remember that IVIg blocks the complement pathway and also the formation of membrane attack complex. And there is no cellular destruction because MAC is blocked. cellular destruction. One of the earliest findings in dermatomyositis is tissue deposition of MAC. It is one of the earliest histopathological findings. And what happens is that this deposition is stopped, and it is stopped in the skin and also in the muscle. So when IVIg is given in dermatomyositis, you see improvement in the cutaneous clinical features and the muscular clinical features also. We know that IVIg decreases ICAM1 on blood vessel, and this leads to decreased migration of inflammatory cells. Decreased migration of inflammatory cells. Okay. So with both of these major mechanisms, what you are doing is decreasing the inflammatory damage. So that's how IVIg works in dermatomyositis. Roughly 2 to 4 months is required to see favorable response in 80% of patients. 2 to 4 months, that means one cycle every month for 4 months. Okay. And give at least for 6 months. That means even after 6 cycles, if there is no clinical response, stop IVIg, consider something else. The IVIg is clearly not working. In pemphigus, bullous pemphigoid, the cicatricial pemphigoid, epidermal acid bullosa acquisita, linear IgA disease, majorly the autoimmune mediated blistering disorders. The IVIg decreases autoantibodies by catabolism. It decreases the binding of desmoglein 3. However, the decrease in binding is seen in vitro only. In vivo studies have not shown it that much. Only in mouse models we have seen that desmoglein 3 antibody binding is decreased. And this leads to decreased inflammatory damage in blistering disorders, decreased inflammation. There is rapid improvement, very fast improvement. It is a good steroid sparing agent. Okay, so remember that in all of these blistering disorders, you need to give a high dose steroid either daily or the pulse form. So IVIg becomes a very good steroid sparing agent. If your hospital has access to IVIg and the patient can get it, give IVIg. Trust me, it spares a lot of high dose steroids. But monotherapy is not recommended. That means only IVIg is not recommended. You have to combine. Better is to combine with low dose corticosteroids or corticosteroids, because remember that IVIg increases the synergistic effects of corticosteroids. Okay, they both act synergistically, so it's better to give it with steroids. Again, give at least for 6 months. That is true for nearly all indication. If IVIg is not showing any benefit after 6 cycles, stop it. It reduces the scarring of vital structures in cicatricial pemphigoid. So remember that in cicatricial pemphigoid, significant scarring of eye mucosa or other mucosal sites happen. And IVIg has been shown to decrease or but decrease the amount of scarring that occurs, thereby decreasing the morbidity of these autoimmune disorders significantly in the future. So if the take home point is that if your patient can get IVIg at the hospital, and if you can easily give IVIg with good monitoring, give IVIg. Now in SGSTN, we've already discussed that fast ligand interactions decreased. Also keratinocyte apoptosis is decreased. Okay, and also all the inflammatory cytokines like 2, 4, 5, TNF alpha, the father of all inflammatory cytokines, TNF alpha, these are all inhibited by IVIg, so you have decreased inflammatory cytokines. So because with these two features, the inflammation is decreased. Okay. Now, a single cycle is recommended. Why? Because we all know that SGSTN is a spike form inflammatory damage to the skin, majorly drug induced, or could be other causes also. So, a single cycle is more than enough, because SGSTN usually doesn't last more than a month. Okay, so let's move forward. Other uses, for example, in atopic dermatitis, it decreases the inflammatory cytokines. It's a good steroid sparing agent. The articles show that it is better in pediatric age group, but not so much in adult onset or adults with atopic dermatitis. In pyoderma gangrenosum, since you have ICAM1 modulation, the neutrophils are not able to migrate to the skin. Okay, so neutrophils are not able to migrate to the skin, and we all know that pyoderma gangrenosum is a neutrophilic disorder. So when neutrophils are not able to migrate to the skin and cause destruction, it leads to good amount of improvement with in pyoderma gangrenosum. Autoimmune urticaria. We know that in IgE or various autoantibodies are implicated, and since IVIg decreases the functioning and production of immunoglobulins and increases the destruction of immunoglobulins, it has shown to have some effect in autoimmune urticaria. In fact, people have given it in chronic spontaneous urticaria not controlled with antihistamines or requiring a high dose corticosteroid for control, and it has been significantly helpful in that. In scleral myxedema, majorly for plasma cell dyscrasias, see, the skin also benefits in scleral myxedema. Okay, the skin benefits. But when you have a B cell dysfunction causing plasma cell dyscrasias, increased amount of autoantibodies or immunoglobulins are being formed by B cells, and that is known as plasma cell dyscrasia from the plasma cells, which are known as plasma cell dyscrasias. And we know that IVIg decreases the formation of all of these endogenous immunoglobulins, and that is why it's very much helpful in plasma cell dyscrasias in scleral myxedema, but the skin symptoms also improve. In pre-tibial myxedema, it's controversial and contradictory. Some articles say it works, some say it doesn't work. I've just mentioned it as another skin area where IVIg is used. So far, we have discussed the uses of IVIg. We already know that there are 15-20 uses of IVIg. I've categorized them into different, uh, you know, different groups. We have also discussed the specific mechanism of action which is implicated in those disorders. If you just go through it, it will be very easy to write a short note on IVIg or answer all the Viva questions. Let's discuss the adverse effects now. Now, adverse effects, the contraindications when you have hypersensitivity to human immune globulin products. So remember, all the absolute contraindication means if you're allergic to drug, you cannot use that drug. Okay. Isolated IgA deficiency or anti-IgA antibodies. So if a person has anti-IgA antibodies or the natural IgA is deficient, if you give IVIg, remember that IVIg majorly has IgG with very low, very less IgA. So you are not giving IgA, and it has been shown that people with IgA deficiency, when they are given IVIg, it may lead to anaphylaxis. Okay, so that is why it's a big contraindication. The boxed warnings include people who have a risk of thrombosis or renal dysfunction or acute renal failure, or patient at increased risk of thrombosis, AKI, blah blah blah. So if the patient has a risk of thrombosis, let's say a chronic smoker or a protein CS deficiency and factor 5 laden deficiency and all sorts, patient taking OCPs, okay, if there's a risk factor of thrombosis, do not give IVIg. The thrombus formation is a very important side effect of IVIg. And renal dysfunction and acute renal failure, kidneys are required for immunoglobulin excretion. So the suprapharmacological doses of immunoglobulins in IVIg may precipitate renal injury, may precipitate kidney injury. So make sure that there is no kidney dysfunction and no kidney failures. The renal side effects include acute renal dysfunction, oliguria, creatinine increase within the first week of giving first cycle. Hypersensitivity reaction include infusion reactions, anaphylaxis, especially if IgA deficiency is present. There is a cardiac overload. See, you are giving a lot of infusion. You are giving a very high dose of immunoglobulin. So heart may not be able to handle that. So that is known as cardiovascular overload. Or a non-cardiogenic pulmonary edema. Again, you are pumping a lot of fluid in the body. If the body is not able to contain that fluid, it's going to deposit it in different areas of the body, mainly the chest cavity. So you will have non-cardiogenic, heart is okay, non-cardiogenic pulmonary edema. Increased coagulability, that is why patients who have a risk of thrombosis, it's ideally not supposed to be used in those patients. Hematological hemolysis. Now, IVIg can cause hemolysis mainly whenever using such a big collection of immunoglobulins, some amount of autoantibodies do go through, and there is autoantibody mediated RBC destruction causing hemolysis. Now, I read one article in which it said that the O group is somewhat safe for hemolysis or the destruction is low in O group as compared to AB and ABO, sorry, AB or AB. So people with O group might be somewhat resistant to hemolysis, but hemolysis can happen in all patients. So be careful with that. Okay, so if a patient has bleeding disorders or thrombocytopenia, you have to be a bit cautious because if the hemolysis sets in, it might be problematic. Hyperproteinemia, of course, when you have a lot of proteins, you don't want to give more immunoglobulins. These are their proteins essentially. Increased serum viscosity. You're giving a viscous fluid, you're giving a uh, solution which has a lot of protein molecules. You are thereby increasing the viscosity of serum. So it's a good idea not to give in patients who already may have increased serum viscosity, namely patients who are severely dehydrated or so. It's better to correct all those things and then think of giving IVIg. Now pregnancy status is C. The newer rating is compatible. Okay, older rating is C, newer rating is compatible. Now let's go through adverse events or adverse effects in detail, and we'll quickly finish this slide, don't worry. Number one is infusion related. So it starts from 30 to 60 minutes after infusion and includes things like headache, myalgia or chills or flushing, nausea, fever. Let me decide. Fever. So whenever you have these kind of side effects just after the onset of infusion, you just decrease the rate. Okay, slow the rate down or you stop the infusion and everything is reversible, it comes back. The moment you feel, that's why you're monitoring every 15 minutes for the first 1 hour. You're looking for infusion related side effects. If anything happens, slow down the rate or even stop the infusion and everything will be okay. Second is anaphylaxis, which is mostly seen in IgA deficiency or autoantibodies, people with autoantibodies. Another hypersensitivity can occur because these are essentially protein molecules, so the body is going to react to them. Dermatitis, erythema multiforme, purpura, alopecia, all have been described with IVIg. Third, fourth is fluid overload. As I'm saying, you're giving a lot of IV fluid over a course of 5 days. So fluid overload, acute renal failure. Okay, especially it has been mentioned that the if IVIg has a lot of sucrose, if it is powdered form, okay, and if it has a lot of cryoglobulins. So cryoglobulin are also just immunoglobulin which gets activated or which leads to cellular adhesion at lower temperature than the body temperature. So those are cryoglobulins. When IVIg has a lot of these things, it may precipitate renal failure faster. The cause of renal failure is osmotic nephrosis, and that is because if IVIg is all of these things. Hematological effects, we have already discussed about hemolysis. There is also transient neutropenia. Remember that ICAM1 is being blocked. So the migration doesn't even happen for the newer neutrophils to exit bone marrow or the peripheral pool of blood and come inside the center. So our body has different areas which are known as pools of inflammatory cells, in which all the inflammatory cells are just resting before they are called for inflammation. And whenever there is inflammation, the body will send signals to these pools that hey, we want neutrophils, we want the cells to come. But these kind of signals require a complex interaction of molecules, and that interaction is blocked by IVIg, and that is why you have a transient neutropenia. But other parameters, other signals, other chemicals are there to take care of that. That is why it is transient, it is short lasting. Okay. Remember, any side effect with the infusion, slow the rate or even stop the infusion altogether. 1, 2, 3, 5, 6, 7. So we have the neurological effects like headaches, septic meningitis have been reported, I think, in around 1% of patients. Photophobia, these are all self-limiting. And people who have migraines might have more chances of headaches and septic meningitis. Okay, so it has been mentioned in one article, so I'm mentioning here. Thromboembolic events. We have told you that it increases the chances of thrombosis. How? It increases the osmolality, increases serum viscosity, and you have secondary thrombogenesis. That is why IVIg should not be considered safe in patients who have increased risk of thrombosis or thrombus formation. Theoretical infection risk. Now remember that you have more than 1,000 volunteers, more than 1,000 healthy donors coming together and giving a part of their blood. And if one of them could be infected by a blood-borne infection, namely HIV, Hep B, Hep C. So the current mechanism by which IVIg is formed, the donors are very carefully selected and screened. They are tested beforehand if they are carrying any infections before taking immunoglobulins from them. Multiple viral inactivation methods, mainly the cold ethanol fractionation method which we use to get IVIg, that is a good method to decrease the viral activation also. Apart from that, there are multiple methods which are taken, multiple safeguards, safe measures are taken so that none of the infection gets transmitted to the recipient of IVIg. So multiple viral inactivation, multiple viral inactivation method and multiple good filtration techniques are used. Okay. Now, how to monitor? That's very easy. Baseline, you take complete history, physical with emphasis on cardiopulmonary system and renal status. Weigh the patient because you need to calculate the dose. So you need to weigh out the patient. Okay. Now, in laboratory investigation, you have to take care of CBC, LFT, KFT, immunoglobulin levels, particularly IgA. Remember, if the patient is deficient, you can land up in anaphylaxis. Okay, so here it is. Yeah, increases risk of anaphylaxis. Screen for rheumatoid factors and cryoglobulins because they have increased chance of renal failure. Remember that I've told you that if IVIg has more cryoglobulins, the chance of renal failure increases. And screen for hepatitis B and C. Now, a good idea is whenever you are giving immunoglobulins, you take a little bit of those IVIg and store it. So what happens is, let's say if a person has a severe reaction to IVIg, which is not limited, or let's say it is not getting better after stopping IVIg, or if the patient has had a new blood-borne infection and will come to you and say that because of your IVIg I've got that infection, it's a good idea to keep a little bit of IVIg stored in fridge and send it to test for HIV, Hep B, Hep C or other blood-borne infections before administering it to the patient, so that you will be sure that the IVIg that you are using doesn't have all those blood-borne infections. Remember, the manufacturers have taken their own course, but it's a good idea to be safeguarding yourself. In follow-up, during infusions, monitor the BP vitals frequently. I've told you it's 15 minutes, every 15 minutes for 1 hour, and then every 30 minutes for the rest of the infusion. Okay. Assess for signs of fluid overload. Keep on auscultated. Remember that pulmonary edema, non-cardiogenic pulmonary edema can occur. Okay. Weigh the patient. If you see increase in weight, of course, the fluid is being accumulated. No specific follow-up or laboratory testing is required. Okay. Other point, there are no significant drug-to-drug interactions, so it's one of the safest modality to be used in immune-mediated disorders. And if you're planning a vaccination, it's a good idea that 3 to 6 months gaps are present before the last IVIg infusion. Sorry, 3 to 6 months of gap between planned vaccination and the IVIg infusion. That means if you have given IVIg, you wait for 3 to 6 months and then you can go for vaccination. Why is that? Because a good immune response requires that the immune system should be working perfectly. But since you have given a very strong immunomodulatory modality like IVIg, it's a good idea to wait for 3 to 6 months. Okay. Now, with this slide, we have finished our discussion on IVIg. I've managed to keep that discussion just short of 1 hour. I know these are long videos, but trust me, all you have to do is just go through one video and you will understand everything about that drug at least at the resident level. Further readings are always required. A doctor needs to read every day, needs to increase, keep on updating their knowledge. few of the articles that I've gone through, good articles. These are all very good articles, and I will copy paste the URL link. All you have to do is just copy paste into your browser, access the full article and read. This includes the IV immunoglobulins in dermatology, part 1 and part 2, one Indian study, properties, modes and action, and one European guideline. This is a very good paper. You should, I would say that you should read this, and you should read this. So these two are very good articles. Go through them and go through this video, and you will understand whatever is required for you to understand for IVIg. So with that, this presentation is over. We have discussed another drug in dermatology this week, and thank you for staying with me and going through these videos. Uh, I make all of these drugs become very difficult to understand during residency, because we don't know from where we should have clear understanding of these immunoglobulins or any other drug for that matter, because it becomes difficult to read from books, because most of the time we spend in our wards or roaming around while doing duties for the patient. So when you have access to these kind of videos, you can just keep on listening to them. Okay, so keep on listening to these videos, and while you're walking or doing your work or doing ward duties, I'm not I'm not at all saying that you should neglect your ward duties. You must not neglect your ward duties, but in your free time, just go about and listen to these videos, and subsequently we'll be covering one drug every week, and you might not even realize that you have covered all the drugs in dermatology with that. Okay, so with that being said, I'll finish this video, and we have discussed one more drug this week, and it is IVIg. We'll meet again next week with some other drug. Make sure you watch other videos like immunopathology of leprosy, one of the very difficult topics to understand. So that video is there. Immunopathogenesis psoriasis, another difficult topic. I've covered a lot of different classes of drugs before this very presentation. So a lot of resources available. Keep on watching. We'll meet again next week with a newer drug in dermatology. Till then, enjoy your weekend. Bye bye. Adios.